All right, good morning, everyone. Thanks for coming in again for our e-lecture series. My name is Philip Wong. I'm one of the MSK radiologists out of Atlanta, Georgia at Emory University. For those of you who've been attending last week and the weeks before, thanks again for joining us. Just again, a little bit of housekeeping. This webinar series is meant for educational purposes only. So attendees have not been given permission to screen record any of these talks, which may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material without permission from the speaker is illegal. We've also disabled all the interactive features for attendees just to make sure that we ensure optimal quality for all the viewers.
Hi, good morning, everyone. This is Felix Gonzalez. I'm one of the MSK attending out of Emory University in Atlanta, Georgia. I have the pleasure to introduce our speaker this morning. His name is Paul Reed. Paul did all his training at Jefferson, great institution. He went to medical school there, did his residency and fellowship, graduated in 2011. He's been in the faculty Jefferson Radiology, the Department of Radiology in the MSK section since then. He's actually undergoing studies right now to finish his MS in health policy. Paul has many awards and recognitions throughout his career, his young career. He's serves as the course director of the MSK Radiology elective, and he's in the committee, the medical school for members of student affairs. With that, I hand it over to Paul. Thank you so much for joining us this morning.
Thank you, Felix, and thank you for that kind introduction. Today I'm talking about imaging the young athlete. Why are we here today? Basically, it's important to understand that when young athletes get injured, their imaging will look different than their adult counterparts. We'll look at why that is, and using some case examples, we'll go through how the imaging might affect how patients are treated. A little bit of background info for context before we get into the imaging. This seems like a high number, and it is, but it actually represents a decrease over the last decade. As we learn more about the risks associated with concussions and repeated subconcussive injuries in young athletes, there has been a significant decrease in participation in sports like football and soccer where injuries like this are common. Specialization means that instead of playing 3 or 4 sports across different seasons, it's becoming more common to play one sport year-round. And with this comes increased risk of injury and also increased risk of burnout or abandonment of sport. Young athletes need variety to grow physically and mentally. And remember your medical student pediatrics rotation. I heard this about 500 times the first week of my peds rotation back as an MS3. And what was true way back then is true today. Between the ages of 6 and 15 years old is the time when young athletes start playing sports. It's also a time of tremendous growth and change physiologically. Kids are getting taller and stronger, but not all aspects of the musculoskeletal system develop in lockstep. One way to think about it, stress on stress, increased demand of sport on top of the metabolic demand of a rapidly growing body. Bones, physes, cartilage, all relatively weak compared to the tendons and ligaments, so a young athlete is more likely to break a bone or avulse an apophysis than tear a tendon or a ligament. After skeletal maturity, injuries in older kids are similar to adults. Although there is an overlap where we will see a mixture of pediatric and adult injury patterns in kids of similar age, depending on how quickly they mature. Male and female, not the same. Despite the recent dip in participation in some sports, overall in the longer term there has been an increase in participation in sport. About 23% for males over the last 30 plus years and about 1,000% for females. And as we learn more about female participation in sport and their participation increases, we gain a better understanding of the injuries that they're susceptible to. Certain injuries like ACL tears, about 2 to 8 times more common in females. Also, patellar instability and stress fractures are more common in females. And why is that? Well, there are a couple reasons. And for example, females have wider hips than males, resulting in more of a valgus configuration at the knee, the Q angle. And this in part may account for a higher rate of ACL injuries and patellofemoral instability. Also, females have more estrogen, which leads to ligamentous laxity, and females stand more upright than males and bear more weight in the forefoot. So as a result, they may be more susceptible to stress fracture in the foot. Beware of this female athlete triad: disordered eating, amenorrhea, and osteoporosis. About 31% of athletes in so-called thin-build sports like cross-country, gymnastics, and ballet can fall into this category versus about 5% of the control population. It may not be a radiologic diagnosis, but increased risk of fractures is a concern, and not just stress fractures. Malnutrition leads to more general abnormal bone metabolism. So females in this category may get fractures from relatively minor trauma or fractures in unusual locations, and when they do get fractured, they may not heal as well. Just a quick word on going through some of the pros and cons of the common imaging modalities. Plain film, readily available, inexpensive, good for fractures, which is going to be the majority of the injuries that you're going to see in the young athlete. Drawback, limited soft tissue evaluation. So ligament, tendons, things like that, not going to be very well evaluated with plain film. CT, it's cross-sectional, so it's better for localization. Oftentimes, surgeons, if there's a chance that they're going to go to the operating room for pre-surgical planning, CTs can be helpful. But drawbacks, limited soft tissue evaluation and radiation dosage, especially in the young athlete. MRI, very good for soft tissue, bone marrow, cartilage evaluation. Drawbacks, limited availability, need for sedation, and relatively expensive. Ultrasound is interesting. It's almost the opposite of CT in that it's pretty good for evaluating the fluid, tendons, ligaments. There's no radiation, but drawbacks are that it's operator dependent. So technologists, radiologists may not feel as comfortable scanning these patients because they're not as familiar with them. And there's also limited evaluation of bone. Ultrasound is kind of limited in its evaluation of bone. So a lot of the injuries that the young athlete may suffer would not be well evaluated with ultrasound. So I've divided this talk by 4 discrete anatomic structures listed here, and I'll show representative types of injuries that can occur. You can further subdivide this into acute and chronic types of injuries that occur at these sites. And then finally, there's this group that I just called unlucky anatomy, and these are diagnoses that we can see in younger patients where some developmental variations increase different types of injuries, and I'll just show a couple of examples there. And this is not meant to be an exhaustive examination of the types of injuries that affect young athletes, more of just a survey and introduction of principles. So keeping that in mind, this is an expert drawing that I've done here, but let's go through the first category, bones. And when I'm referring to bones here, I'm really just meaning the diaphysis, so this region here. So basically the shaft and the periosteum. And compared to mature bone, immature bone demonstrates greater resiliency and elasticity, has a thicker periosteum. But it's a little bit different in that from the adult, in that the acute injury you're going to get buccal or incomplete fractures typically, as opposed to the kind of the standard non-displaced or displaced fracture that you would that we're more used to seeing in the adults. Then chronic injuries like stress fractures. So here's our first case: 7-year-old female, fall from a bike. And this is just, a classic buccal fracture of the distal radius. I thought I'd start off easy. And here we have just some trabecular buckling as a result of an axial loading injury. 17-year-old female cross-country runner. These are actually images that were of the patient from 1 year prior. And here we can see pretty intense bone marrow and periosteal edema in the midshaft of the right tibia there. I think we have to be very cautious or cognizant in terms of making sure that we categorize these appropriately. So in something like this is very severe stress response. And we would have to consider the fact that there might be a stress fracture here. Sometimes the field of view, especially for something like a tib-fib study where the field of view is relatively large, it might be difficult to clearly identify a fracture. Sometimes there's motion that might make it a little bit difficult. But what you want to be, especially with stress injuries like this, you want to make sure that we put these in the proper categories so that the patients are given the appropriate time to heal and to prevent any complications from them coming back to activity too quickly. So this was 1 year ago, and this is just a follow-up that we read probably within the last week or so. And on the current exam, you can see this patient returned to activity and developed new pain more distally in the leg. And now we see here the completed fatigue fracture of the distal fibula on our sagittal T1 image. And then on our coronal fluid sensitive image here, we have, you can see again the fracture and then the associated periosteal and marrow edema. This young athlete has 2 risk factors for fracture: the female sex and long distance running. And so it's it can be difficult with these young athletes. I mean, they really want to get back on the field. They might have a college scholarship at stake. Their friends might be playing, and just the natural, competitiveness that a lot of athletes demonstrate. It's tough for them to stay on the sidelines, and unfortunately, injuries like this can recur, like we see in this case. So let's move on and look at some physeal injuries. Now the physis here, kind of the engine room where bone is developed, a very vascular region. It's vulnerable to disruption, especially from shear forces. In an acute setting, you're going to have your Salter-Harris fractures. I don't want to spend too much time going through every single one of these Salter-Harris classifications. Many of the lower grade injuries are diagnosed on radiographs and do pretty well with conservative therapy, although occasionally we do see higher grade injuries on MR, so I'll show you an example there. And then the chronic injury to the physis, just typically from repetitive loading. So here we have a 17-year-old female fall from a skateboard. And the initial frontal radiograph of the ankle, you see a vertical component of fracture here through the distal tibial epiphysis. And then coronal and fluid sensitive imaging. And here, again, we can see that fracture, the vertical component going through the epiphysis. And then there's actually a horizontal component going through the physis here. And on our sagittal images, we can actually see it extending almost obliquely through the metaphysis. So this is a triplane fracture. It's a Salter-Harris 4 fracture. But the reason that I wanted to show this case is that I'll just go through and show you. You can actually see as you scroll through, there's this linear kind of low signal kind of fragment within the physis here. And that's a potential complication of pediatric fractures. This is periosteal entrapment. Fractures in young people can result in stripping or displacement of the periosteum. And if the fracture extends through the physis and there's some widening there, that creates a potential space for the periosteum to migrate into. And if the chunk of the periosteum that flips into the physis there is large enough, the fracture may not be able to be reduced appropriately, and this increases the chance of premature physeal closure. If this happens to be the case, then surgery is usually indicated to remove the periosteum and allow for adequate reduction of the fracture. So this is an important complication to be aware of. So moving on, those are the acute types of injury, and I'm going to move on to some of the chronic repetitive loading injuries that we can see in the young athlete. And in this case here, we have a frontal radiograph of the shoulder, and this is the patient's throwing arm. And here we can see that there's a little widening here of the lateral proximal humeral physis. It can be a relatively subtle finding on radiographs. Mild irregularity of the physis can be within normal variation. It might be helpful in certain cases to obtain a radiograph of the contralateral shoulder just to compare side by side and see if there's a difference. This patient did go on to MR imaging, and here we have a coronal T1 image showing mild widening here of the lateral physis, and then our fluid-sensitive coronal sequence here showing some associated bone marrow edema. And this is proximal humeral epiphyseal lysis, or little leaguer shoulder. It represents a Salter-Harris 1 injury that results from torsional and distractive stress across the physis, typically throwing and especially pitching. typically requires an extended period of rest, 3 months or so of no throwing, then rehab and gradual return to activity. I kind of mentioned the potential complications with too much specialization, but I think one positive trend in youth athletics recently has been the increase in awareness of the need for proper rest, especially in these throwing athletes. I have nieces and nephews that play baseball, and they know how many pitches that they can throw before they need to come out. The coaches stick to it, and so I hope we may get this a little bit kind of under better control as we become more and more aware of the detrimental effects of overexertion. So here we have a 14-year-old female gymnast, and so we're moving basically from one stress injury to a different one. And here we have coronal CT imaging of both wrists, and we can see some physeal irregularities, some widening, and some surrounding sclerosis. This is gymnast wrist. It's similar to Little League shoulder in that it's a Salter-Harris 1 injury of the distal radial physis due to repetitive overloading. And if we look at the coronal or the scalp tomogram and the CT in this case, we can see that the findings here have advanced to the point where there's a pretty significant ulnar positive variance bilaterally, and this is concerning for premature radial physeal closure. This patient was anticipating a college scholarship and was having a lot of right wrist pain, and eventually went on to have an ulnar epiphysiodesis on that side in an effort to limit the length discrepancy between the radius and ulna and get back to competition. So there can be some pretty significant consequences to these chronic overloading injuries. So, all right, that's a little bit about the Physeal injuries that we might run across. Now let's move on to the Apophyses. I did another little just kind of diagram here, and I just wanted to show that just in this case that I chose the fifth metatarsal almost at random. It was kind of easy to draw, but this point in this whole diagram is the weak point. So you can see there's this kind of normal strong tendon, relatively strong metatarsal shaft, but this small bony apophysis and the little bit of cartilage holding it together is the weak point. And that applies more broadly to other apophyses around the body as well. Most of these injuries occur between 8 and 15. As kids enter puberty, they become, they get a lot bigger, they grow stronger over a relatively short period, and their muscles can generate a relatively large force across tendons. And this can overwhelm the relatively weak apophyses, especially the larger groups like hamstring, medial epicondyle. In the acute setting, patients often feel a pop and then pain. And in the chronic setting, it may be more insidious. Symptoms may wax and wane. One common thing might be that Osgood-Schlatter's is a classic chronic apophysitis. And, growing up, I used to see kids in school that would come in with a knee brace for a week and then, not have a brace and then kind of have the brace on the other knee. So, that's just, kind of the classic kind of presentation that symptoms that these kids have. And let's review some of the injuries here. So here we have a coronial and axial large field of view fluid sensitive sequences here. And we can see bone marrow edema here. And here, this is at the anterior inferior iliac spine. So that's at the rectus femoris tendon attachment. And this young patient felt a pop after kicking. As we move to our small field of view sagittal sequences, here we have, again, we can see that apophysis, the avulsion, and then there's a little distraction, maybe about just a few millimeters. And this is just the result of a strong contraction as the patient went to kick. There's a lot of, you can generate a tremendous amount of force from that muscle, and when that gets applied to the tendon, the apophysis may give way. And you can see that that was the case in this situation, and there was a little bit of distraction. These injuries are typically treated conservatively. There's a recent meta-analysis from Germany that suggests that there may be some benefit from doing operative fixation if there's greater than 15 millimeters of distraction. So if you do see a gap, it's important to include the measurement, as it may potentially influence the choice of treatment. Let's go through another example here. It's a 20-year-old male track athlete, and here we have a frontal radiograph of the pelvis. He felt severe left groin pain after sprinting, and we can see that there's a small bony fragment here, just slightly displaced from the left pubic symphysis. And on follow-up MR imaging on the coronal T1 here, you can see that little bone fragment representing the pubic apophysis. And on the coronal T2, or fluid-sensitive imaging here, you can see some associated stress edema. And here at Jeff, we've done a lot of research on imaging core muscle injuries at the pubic symphysis. And this represents the immature or kind of maybe juvenile version of the injury, more commonly known as the sports hernia. And these injuries result from imbalances and forces between the rectus abdominis muscles of the abdomen and the adductor muscles of the thigh. In the adult population, it's the aponeurosis that gives way and can detach. And in younger patients, the apophysis is the weak point instead because it hasn't fully fused. And so that's what we see here. These injuries, they may be treated conservatively at first. If it doesn't improve or it recurs, there's an operative technique called the pelvic floor repair that you can do to help stabilize these injuries and help them heal. Moving into the more chronic category, this is a 14-year-old male baseball pitcher. And I like this case because we have two slightly different appearances of the same phenomenon in this one patient. And both of these injuries represent chronic traction injuries related to throwing. Here on our coronal fluid sensitive sequence, you can see mild widening and irregularity of the medial condylar physis. And then on the sagittal image here, you see this edema across the olecranon physis. These just represent traction injuries. So there's a little stress edema here, and here it's the physis that's actually kind of starting to widen a little bit. And these injuries are typically treated conservatively with a period of rest and rehab. The adult counterpart to this injury is, after skeletal maturity, is that the ulnar collateral ligament here fails, and that's just really, these injuries here are just related to the chronic valgus stress that comes from the throwing motion. But the ligament injury that the adults suffer is pretty significant, and they often have to have reconstructive surgery called the Tommy John procedure, and it takes about a full year to come back to the sport. So the younger patients actually do a little bit better because the bone, the apophysis can heal relatively well without surgery, just managed conservatively. All right, let's move on and take a look at cartilage. So we're looking here at the articular surface. Younger cartilage is thicker, more plastic than mature cartilage, and has a capacity to remodel. But despite that, it's susceptible to certain stresses, especially shear stress. Injuries can be acute or chronic, and I'll just show an example actually that's kind of both in the upcoming example. So here we have a 13-year-old male baseball pitcher. And if you're sensing a theme here, you're not mistaken, is that throwing is a particularly stressful activity for the young athlete. And if not managed appropriately, it can lead to potentially significant injuries. And I mentioned earlier the pitch count limitations. I think also it's important to limit the type of pitches that young athletes throw. Curveballs and breaking balls, anything where you have kind of a snapping motion, including in the throw, in order to add an extra element of motion on the pitch can lead to injury. So I think it's important to hold off on letting kids throw those kinds of pitches until they're physically capable of handling them. So here in this example, we have the same patient with a coronal fluid sensitive sequence here, and then there's the follow-up image 6 months later. So on the initial MRI, we can see that there's pretty intense bone marrow edema here localized to the capitellum, and a small amount of fluid here related to an osteochondral lesion. And that comes from, we mentioned that there's a valgus stress on the medial elbow with the throwing motion, and on the radial side there's an impactive phenomenon, so you can get injuries to the cartilage like an osteochondral lesion. And in this case, with this little bit of fluid undermining the cartilage, it's worrisome. It suggests that it's unstable. And as we see on the follow-up imaging, that the edema has gotten a lot better. But whereas there's a cartilage defect here. So this is new. So the edema is better, but the cartilage is now a problem. And anytime you see a cartilage defect, it's important for the radiologist to see if they can find it. And on our axial imaging from the initial study, this is the anterior joint recess here, there's not much, but you can actually see a cartilage fragment on the follow-up study. So that's important. This particular situation, when you have a displaced cartilage fragment like that, is a surgical case. They can try and reattach or kind of anchor this cartilage osteochondral fragment back down, but if that's not possible, they may have to do a graft. And in more or less severe cases where you may have just a small amount of edema in the subchondral bone, not actually fragmentation or undermining fluid, then those lower grade lesions where it's just edema, they may be managed conservatively and just see how they do. But in a situation like this needs to be addressed surgically. Unlucky anatomy, a little bit of a grab bag of diagnoses. There's some relatively minor variations in normal development that can affect young athletes, either putting them at increased risk of injury due to instability or overuse. Here I'm just going to show two examples: transient patellar dislocation and cam-type femoral acetabular impingement. So a 14-year-old female fell to pop playing basketball, and on our axial fluid-sensitive image here, we have the classic appearance of a recent transient patellar dislocation. Here we have a large hemarthrosis with a layering fluid level and reciprocal contusions at the medial patella and lateral femoral condyle. You can also get the sense that there's probably a medial retinacular injury as well. In addition, this is showing the morphologic variations that predispose to instability. If we looked at the trochlea is shallow here, and there's also kind of what we would call the Weiberg 3 kind of morphology of the patella, where the medial patellar facet is short and vertically oriented, and the lateral patellar facet is elongated and kind of horizontally oriented on these axial images here. So you can kind of get the sense that just the combination of these developmental variations, there's a pretty good chance that at some point this would slip out laterally, and that's what's happened here. These injuries are problematic in that they often recur and may lead to early onset osteoarthritis. And in this case, actually, we could see on the sagittal fluid sensitive sequence, there's actually a little cartilage fragment that's been displaced. So this may be one where they need to go in and kind of address this surgically relatively earlier on, whereas if it was, maybe no fragmentation and just maybe a less severe state of injury, that this may be managed conservatively. But this one probably should go on to see if they can address that cartilage fragment in the operating room. All right, our next little variation in normal here. This is a 16-year-old male hockey player, and this patient was coming in for an arthrogram. So this is the frog leg lateral scout radiograph prior to doing our arthrography. And here you can see that there's this bony prominence here at the lateral femoral head neck junction. And one of the side benefits of doing an arthrogram is that you can give a little intra-articular lidocaine and go through some passive range of motion through the impingement arc and just see whether there's a change at the beginning and at the end of the procedure. And this patient was pretty uncomfortable in the beginning, maybe 6 or 7 out of 10 with going through the impingement arc before we gave intra-articular lidocaine, and then had almost near complete relief afterwards. So this strongly suggests that the majority of the pain is coming from something inside the joint. And then when the patient goes on to MR, we can actually see that the anterior superior labrum is not looking very good. Here, if you just compare the posterior labrum, kind of uniform low signal, kind of a nice morphology there. Here with kind of very irregular, has probably some contrast within the substance of it, and it's partially detached at the base here. So this is an anterior labral tear, and again, you can see that little bony prominence here. So as this hockey player, he goes to push off, we see this very often in hockey players. These guys are particularly at risk. This little bone, this little bony outgrowth here is going to impact up against the labrum and cause injury. And then if not addressed, then eventually this will lead to cartilage injury and early onset osteoarthritis. Treatment, they may start out conservatively, but a lot of times that may not be all that helpful. It requires surgical correction, in which case a lot of times what they'll do is they'll just go and kind of excise this bony outgrowth here and either debride or repair the labrum, depending on how it looks. And what PEDS lecture would be complete without the classic, is this something or is this nothing kind of cases? Like, is this a normal variant or is it a real injury? And I'm going to show two cases. First, 14-year-old female softball player with pain, and the only abnormality is what we see here. On our T1 image, there's just this little kind of irregularity of the physis here with some corresponding high signal on our fluid sensitive sequence. This is what we would call focal periphyseal edema, or FOPE. Kind of looks like a little asterisk to me, sometimes almost like a little centered at the physis with little spokes kind of radiating away. There's some thought that these may represent some microtrauma kind of stress injuries across the maturing physis. We don't really know for sure. These patients are not treated surgically. We don't go in and biopsy these things, so we don't know exactly what it represents. But something to consider if you have a finding like this and no real other explanation for the injury, you might consider that, I would, in this case, just describe this finding and say it has been described as a source of pain. So it's thought to be a limited, a self-limiting process and doesn't require any specific follow-up, but it's something that you should be aware of. And finally, here we have the case of an 11-year-old female with lateral knee pain and a script to evaluate osteochondral defects seen in the lateral femoral condyle on X-ray. And we didn't have the X-ray, but we read the MRI. And here's what it looked like. So is this an OCL? Well, there is some focal subchondral signal alteration, but if we look here, the overlying cartilage is normal. And if we look on our fluid-sensitive sequence, there's no edema around this. And this is a pretty classic location for just a normal ossification center. And in this case, that's what we called it. And in fact, as we go on, this patient actually had, the real injury was a little subchondral fracture of the lateral tibial plateau. And this is a nice example because in this case, this injury should heal without complication, whereas an osteochondral lesion may progress, warrant further imaging, or maybe even intervention. So it's important to recognize this little variation and label it appropriately to avoid confusion later on. So in summary, we've reviewed some common injuries unique to the young athlete. We've gained some familiarity with the mechanisms by which they occur, touched on some management issues, and I always keep Keith's book of normal variants handy. I think that's a great idea when you're imaging the young patients, especially the cases where something might look a little funny and it doesn't quite match up with the provided clinical history. So just remember that there's some normal variants there that can kind of trip us up. These are some of the references for the statistics and data that I cited. And thank you very much and have a good day.